Hello, everyone. Namaste. Assalamu alaikum. I'm Dr. Tauseef Ali. I'm a gastroenterologist, and more importantly, someone who deeply cares about helping people live their best lives with IBD, whether it's Crohn's disease or ulcerative colitis. Welcome to our SAIA Patient Education Talk series, your apni jaga, your own space to learn, ask, and connect. The goal here is very simple: take these confusing technical medical topics and make them as easy to understand as a conversation over a chai. Today's session is called Demystifying Biologics and Biosimilars in IBD. And I know, ye kya hota hai? What even is that? Sounds like something out of science fiction. Um, don't worry, hum sab samjhayenge. We'll explain everything. We are going to break it down: what biologics are, what biosimilars mean, and how they work, and why they can be game changers in IBD treatment. And to make it even better, we've got two amazing patient advocates joining us today who will be sharing their real stories, Zindagi ki Asli Kahaniya, about living with IBD and navigating these treatments. So grab a cup of chai or coffee, whatever you like, get comfortable, and let's get started. Because knowledge is power. And आज हम मिलकर अपनी सेहत के बारे में और जानेंगे. Today, we will learn more about our health together. So, I'm going to introduce our panelists here. We have Dr. Joshi and Aisha and Tanya here. I'll let them introduce themselves.
Hi, I'm Dr. Harshad Joshi. I'm a consultant gastroenterologist and IBD specialist. I practice from Mumbai, financial capital of India. I look at a lot of IBD patients. The numbers in India are slowly and steadily rising. So it's really an interesting, and because now we are using so many biologics, so it's really an interesting topic, Tauseef, that you picked up, and I think it should be a fruitful discussion.
Hi, everyone. My name is Aisha, and I'm a Crohn's disease patient. I've had the disease for about 2 decades now. I live in California, and I work in the technology sector. I have 2 children, and I'm happy to be here to share more about my journey.
Hello, everyone. My name is Tanya, and I was diagnosed with Crohn's disease in 2000. So I've lived with it for about 25 years. I am from Chennai, India. I am married and I have a 10-year-old son. I am really looking forward to today's discussion with all of you.
Okay, great. Wonderful panel. We'll have a great discussion. So, I'll just start. Dr. Joshi, how do you tell patients about what is a biologic and why they are critical many times in IBD management?
Tausif, like biologics are basically proteins or large molecules which are used in patients who have a severe form of IBD, be it ulcerative colitis or Crohn's disease. So people, when we categorize them based on their clinical status, those with moderate to severe symptoms or with complications, these are the medications that we use to get their inflammation under control. Some of them are injectable ones, but nowadays we are also getting some tablet form of biologics or small molecules which are available, which are very good in controlling the inflammation to a normal level so that they can have a clinical and endoscopic remission.
Okay, great. Yeah, this is how I tell my patients also that the biologics are kind of like special types of medicines, and they're made from living cells. Yes, like jite jagte cells. They're not like your usual pills or tablets that are made from chemicals. They are big, complex, protein-based treatments. Um, I give this analogy to the patients that, think of your immune system as a security guard. Normally it protects your body, but in IBD वो guard थोड़ा सा overactive हो जाता है. The guards get a little bit overactive, and now it starts attacking your own gut, and that's where biologics come, and they help calm down the guard without shutting down the whole system. And that's why they are targeted. They get the inflammation in the gut control. They help you get off the steroids, and we all know how bad steroids are and the side effects of steroids. And they promote healing. They actually help your intestine heal, and then they give you a better quality of life. So that's how I explain that. So that's great.
Thank you, Dr. Ali. So that's very interesting. I mean, it looks like it's definitely better off than steroids. Thank you for that explanation on biologics. Can you tell us how similar or different biosimilars are to biologics?
Yes, great, great question. So the way I tell what biosimilars are is that they are. Let's talk about biologics for a second. The way I will explain and then go to biosimilars also, that these are like your high-tech living cells, and they're made into medications. And biosimilars are their siblings. Just like the name says, that they are similar, they are not copy paste, but almost identical. And then I give this example to explain biosimilar. It's like your body is like a house, and there are many doors inside, and you need to keep them closed so that everything is safe and functioning properly. Biologic is like a special key. It is designed to close the specific door, and it's made in the lab through living cells. So it's very unique, custom made key that just locks that door where you want that to be locked. Biosimilar is like a new key. It's made to close the same door, but it's cheaper, and it's not the original key, but it works just as well because it was created to fit the same lock in the same way. So it may look different, the key may look different, maybe in the color, but it still closes the same door securely, just like your original key. So even though the biosimilar isn't exactly the same key, it still is very effective in closing that door or lock, so the body get the same benefit from it. So it's safe, it's affordable than original biologic key. So how they are similar? They have the same ingredient, they have the same strength, same dose, same results, and same safety profile. And how can they be different? They may come in a different packaging. They may be coming in a different injector pen. And usually they are more affordable than your actual drugs. So that's how I explain biosimilars to the patients.
That's a
I
very interesting analogy, Doctor. In fact, we all have made spare keys to our house, I'm sure. So that's a lovely analogy. We can all understand that. Dr. Joshi, would you like to add something to that?
So, yeah, Tausif has really elaborated it very well. So, if I have to just give a example from the kitchen, like if I like say bread and I know the ingredients, how the bread is made. So, I have the recipe, I make it at my home, and then I bake it, cut it into pieces. So, each and every loaf, I mean, each and every piece of that loaf of bread may not look exactly the same, but it will have the same ingredients, it will taste exactly the same. So biosimilars and the biologics, they are that way similar. I mean, they have the same structure. So obviously that means they have same efficacy. They have same route of administration. So the way you were receiving your biologic, similar way you will be receiving. So if it was injectable, you will be receiving injectable biosimilar. They will have same safety profile. So they're obviously run through a lot of mechanisms by which, I mean, before they come into market, it's made sure that efficacy wise they are same, safety wise they are same. So there are no additional side effects from a biosimilar that you would experience that you will from the biologic. So profile, safety profile wise, they are exactly identical. Now, the good part about biosimilar is they are less costly, right? So, especially in cost constraint areas like places like India or Southeast Asia, where there are no insurance policies which are available, and where the patient is paying from his own pocket. unlike the Western world. So here the first question that the patient asks is, Doctor, मेरे को पैसा कितना लगेगा, or how much would I have to pay, right? So biosimilar that way come very useful for our population, because when we know that the patient requires biologic for the mechanism of action, and when they can't afford the cost, this way the biosimilars come very handy, and we can use it to more and more number of patients so that they get benefit, and at the same time they don't have any side effects.
That helps us understand a little bit more, because there's always this question like, is the quality of the biosimilar the same as biologics, or, especially if it's the same modality? And the other question is, if they're infusions, like, are the biosimilars also like, are they considered chemotherapy, or how do you explain that?
They are not chemotherapy, like they are protein molecules which control the inflammation. These are basically like keys to the inflammatory pathways, where you just close the lock so that the inflammation can be brought under control. Uh, the chemotherapeutic agents behave a little differently, where they are suppressing their immunity, but they are not specific. They can target each and every cell. That's why you see a lot of side effects from chemotherapeutic drugs. But that's not the case for biologics or biosimilars. They are targeted against a specific pathway in the whole inflammatory process, so that you can just block that particular thing, so that you are acting only in the inflammation which is causing damage to your intestine, whereas it doesn't affect any of your other bodily structures. So that way it becomes very specific. They are definitely different than a chemotherapeutic drugs.
Yeah, and I'll add to that. I'll jump in here and add a little bit of my perspective and a little bit that I learned. It's a great question because when I was getting training, I used to mistakenly say that to my patients. They are like drugs, like chemotherapy drugs, and then I got corrected that, and I learned about it, that how scary this word could be. Even the word biologic is so scary to many patients, and that's why I have started shying away from the word even biologics. They think these are like weapons of mass destruction. So I just use the word advanced therapy or targeted therapy, and so the way I tell my patients, and typically I proactively tell them that there are four myths, and I'm gonna tell you how they are wrong and how you need to stay well informed. Because one of the things that I have learned, that IBD patients they deny a therapy, they run away from a therapy, is basically three things. Number one, that they are misinformed, and number two, they're scared, and number three, they may still be in a denial. So it's very hard to get them out of the denial. But as a physician, my job is to make sure that I alleviate their fears and I help them stay well informed. And that's where the myth number one that I say comes, that biologics and biosimilars are like chemotherapy drugs. So I try to explain to them that they're not chemotherapy drugs. They are targeted immune modulating therapies. They modulate your immune system, and they're not cytotoxic. They're not like killer cells. Chemotherapy, they attack fast growing cells like cancers, while biologic therapies, they target a specific pathway in your immune system that is overactive in IBD. Think of this way: instead of dropping a bomb like a chemotherapy, biologics are like guided missiles. They go straight to the source of inflammation without causing less damage to the nearby areas. I mean, there are some side effects and risks that you have to consider, but mostly this is kind of like an analogy I give them to help them understand that why they are better. The second myth is that the biologics are last resort. Like, I'm scared to use these drugs, and if I'm using it as a last resort, actually, no, we are using biologics now early on because not that the patients are worse, it's because we have learned that early control of inflammation leads to better outcomes. That's why we bring biologics, we bring biosimilars early on in controlling their disease. Myth number 3, that they are injections and infusions, and that's why they must be dangerous. And that's why I explain to the patients that their route of administration, like giving these biologics and biosimilars, IV or under the skin, has nothing to do with the danger. It is just that's how they get to the system. Because imagine if you eat or take it orally, biologic, these are proteins. These proteins will be destroyed by your stomach acid. So they're not going to work unless we develop a mechanism where we can save them in your digestive tract, these proteins, because the function of your digestive tract is to digest the protein. And that's the only reason we are thinking we are giving these drugs through IV and sub-Q. Doesn't mean that they are dangerous drugs, and that's why you are going to be on IV and sub-Q. And the last myth is that the side effects are worse than the disease. The fact is that all medications, they do have risks and side effects, but for the most patients suffering from Crohn's disease and ulcerative colitis, the benefit outweighs the risk, especially when the alternative is ongoing inflammation, repeated steroids, hospital visits, surgery, and the risk of this persistent inflammation leading to cancer. So we really need to carefully weigh your personal risks and benefits. And then I just tell them that, आप अकेले नहीं हैं. We are here to help you. You're not alone. And we are here to help you get the disease under control, inflammation under control, so not only we prevent you from having complications, but also give you a better quality of life. So I'm going to ask a question to Tanya.
Yeah.
We know that these myths exist that I just shared, but let's hear from you. That I think in our discussion before we went live, you were mentioning about starting on adalimumab biosimilar. How did that work for you? And did you have any concerns and trouble starting or staying on it? And how are you doing now?
So actually listening to you dispelling these myths, these 4 myths, it was like deja vu because I was going back to, it was really like flashback. So I'll tell you what happened. So it was 3 years ago, exactly this August, that I started flaring very badly. My body refused to go into remission with only azathioprine, which was the drug that I was on then, which is a drug I had been on for several years and which was doing okay for me. I had had a pregnancy, everything with azathioprine. So to know that I was failing that drug and I was flaring, I couldn't do any of my daily activity, even something as simple as dropping my son at school became a nightmare. And that's when I was clearly struggling and I was advised to begin a biologic. But naturally, I was apprehensive. All of these myths came up. My family was worried that I was, now requiring a higher level of therapy. It was no longer just a tablet, and somehow an injection feels like a much more serious level of treatment in our minds. So it was a big step, no doubt. But when I look back at the past 3 years after beginning, the adalimumab biosimilar, how full my life has been and how much I've been able to do with my life, I'm glad I took the step to move to the biosimilar. And in India, when we're counseled for a biologic, it's made absolutely clear that we're getting the biosimilar because the biologic is not available in India. The originator molecule is not even available in India. But for all practical purposes, if I were to go for a consult to another gastroenterologist, we only mention the biologic by name. We don't even get into the name of the biosimilar. That's how effective the biosimilar is to the biologic. And frankly, until this discussion, I never realized that there was anxiety in the Western world on getting onto a biosimilar versus a biologic. So that's my take, doctor.
Great, wonderful. I think that's good. Thanks for sharing your experiences and your life journey. Really appreciate that. Turning to Aisha. In the United States, as Tanya was rightfully identifying and recognizing that there's this concern among some patients, family members about switching from biologics to biosimilars, and we're seeing that increasing cases of switching from biologics to biosimilars are happening due to the drug patents expiring and health insurance companies wanting to cut costs, because we know that biologics are very expensive. And we also know that Europe and in Asia now, they have been switching and starting. And as Tanya said, they may not even start on the biologics, they just go with the biosimilars. So Aisha, I understand that you were switched from a ustekinumab originator molecule to a biosimilar this year. How was your experience with that switch? And what would you like to share with other patients who may have been asked to switch to a biosimilar?
Yeah, no, thank you for that question. So, Dr. Ali, it's always very, I guess it causes a lot of anxiety whenever I hear there's a switch in my medication, because historically, like I've switched from infliximab to vendozilimab and then adalimumab and then ustekinumab. And now when this news came, it wasn't actually even communicated, to be honest. It was just when I had a refill at the dosage and frequency that I usually get, I noticed the name was different, and I was like, wait. So as I picked up the sub-Q at the pharmacy, the pharmacist consult is who explained to me that we're making this switch. It's exactly, the same medicine. It's just a different name, but it's considered a biosimilar. And I just recalled all my anxiety of, it's like whenever I've had to switch, it's because the medication stopped working. And I'm like, wait, no, it's working. I'm feeling fine. Why are we making this switch, right? So there was some of these questions. And I feel like any of the patients in the United States or elsewhere who are having to make this switch or are suddenly surprised that they're going to be switched, communicate with your doctor. I feel like this is something, maybe more transparency or more communication would have eased my apprehension. This is something that could be, kind of planned as a smoother transition as opposed to a surprise. But overall, starting on this medication, and it's been a few months of kind of watching and waiting, and it's been seamless. Like I feel I've stayed in remission, thankfully. And to me, other than the name of the switch of the drug, I don't really notice anything different. So it's in hindsight, I was getting a little bit anxious for no reason. I feel like this was very much a smooth transition.
Great, wonderful. Thanks for sharing these reassuring experiences with us. I think that's wonderful to hear from the patients. So yeah, good. So I think I'll add a few things to what Aisha just said, because just like Aisha had this anxiety and a surprise that why my MAB is changing to a different name. So and believe me, one thing I will admit, there are many MABs now, these monoclonal antibodies or biologics and biosimilars. Sometimes I even have hard time keeping track of all the names and remembering those names. And one thing that I think if I could go back, instead of using these trade names, if I would have just used these generic names to the patient, I would have created less anxiety among myself, my staff, and my patients, because we used to call the trade name. And then when all these biosimilars came, they came with the generic name of a different MAB. So it was kind of like, wait a minute, you were prescribing me this, the different name, and now you have this different name. So what just happened here? So it's a matter of trust also. So I think the way I explain to the patients about like what questions you should be asking your physicians when that surprise happened, or before surprise, about switching to biosimilars. It's completely natural because you want to have a clarity and reassurances. That's very critical when it comes to the management of IBD, is to be very clear. And one thing I always tell my patients, the last thing I want you going to north and I'm going to south, and we both have our own separate ways. We want to make sure that this journey, we are together, we are understanding, we are making decisions together. And here comes to my conversation and the patient going to the pharmacy and getting a different medicine next time. Sometimes it's even a change in the color of their pen. Or sometimes I remember patients would come and notice, like, wait a minute, what is this vial hanging? I was supposed to be on this medicine, and what is this medicine? So it was those kinds of surprises. So I think what I want to tell my patient is that the switching is common and it is evidence based. Biosimilars are highly similar to their original biologics. The switching is backed by scientific studies and it is supported by professional groups in America, in Europe, in UK, and even in South Asia now. And countries like United States, UK, Canada, they have safely switched thousands of patients to biosimilars with no loss of effectiveness or any increase in side effects. But you should be part of the conversation, and shared decision making is critical. So you have the right to ask the questions, understand the plan, express your concerns, and a good doctor will support this discussion without making you feel rushed or dismissed. The common questions that you ask, like, why are we switching? You need to understand that the switch isn't happening because my insurance is asking that. There's a hospital policy, or the infusion center is now carrying in biosimilar. Is it because of the cost? Is it because of the availability? As Tanya was saying, that there is not even a biologic available to this one particular biosimilar, and they just get started on a biosimilar. Is this biosimilar approved for IBD in the United States or my country? Good question to ask. How will I be monitored after switching? A good question to ask. Will you be monitoring me same or differently? Will it be through blood tests, symptoms, endoscopy? What should I be watching for? So all these are good questions that you should ask if you are being asked or you are being switched to a biosimilar. Will I receive the same support? The nursing, the injection training, the copay assistance that happens in United States and many other countries. And then there is another question that sometimes patients ask, and you can ask this question is, can I be switched back to my original biologic if the biosimilar doesn't work? That's a very tricky question. Yes, in most cases you can go back, but we really need to see why the biosimilar is not working. If it is not working because you have now more inflammation or your inflammation is getting worse, then you may need to just change to a different drug with a different class or different mechanism of action, because it seems like that drug, for example, if it is blocking TNF alpha, maybe you need to block interleukin 23 now, because TNF alpha pathway is not blocking adequately or appropriately, and the inflammation is being driven by a different immune pathway. And remember, I had this discussion early on about like how these are targeted therapy, like guided missiles. So you really need to see where exactly you need to hit so that you can close that door of inflammation. So in summary, I say that your role as a patient is be informed, uh, do not get afraid. Biosimilars are designed to make care more affordable without uh, kind of like sacrificing the quality. Ask questions. No concern is too small. Your voice matters. And then stay engaged. Monitor your health, follow up the labs, and communicate with your team. You deserve the care that is effective, affordable, and personalized. So turning back to Dr. Joshi now, I understand that biosimilars have been more commonly used in parts of Asia, as Tanya flagged. In your experience, how have biosimilars shaped access to robust and effective IBD management in India and South Asia?
Okay, so Tauseef, this was a really good discussion. I'm sure that I'm going to help this to educate my patients as well about this. This particular scenario doesn't come too often, about when the patient comes and asks me about, am I going to get switched from original to biosimilar, or is it safe or not? Many a times, because just to give an example, Humira or adalimumab, that's the original molecule. So in India, Humira is not available. So what we have been prescribing for each and every patient in India is the biosimilar, and it is working really well. So I think for us, and I'm sure the same analogy can be implemented even to the Western patient, is like biosimilar work exactly the same as the original molecules, because we see that day in and day out in our clinical practice. Second thing about the infliximab, yes, we have infliximab available as the original molecule as well as the biosimilar. And when we have seen that we have to switch, for example, some patients we start with the original molecule, and sometimes we have to switch them to biosimilar because the biosimilars are about 30-40% cheaper. Okay, so that means that you are saving 30-40% money in the medication, which you can utilize for continuation of care. So that way we don't have to stop the molecule abruptly, we can continue the medical management for a longer period of time. And there are, I mean, it's like you said, it's backed by clinical evidence that there is no difference as far as the efficacy is concerned, there is no difference as far as the side effect profile is concerned, and the bioavailability is concerned. So they are exactly the same. So when we are getting the molecule at a cheaper rate than the original molecule, we can penetrate or give this benefit to more and more population. We can give it for more duration of time so that they remain in clinical and endoscopic remission for a protracted period of time, because we know that getting the inflammation under control is the key to preventing any short and long term complication. So yes, it is definitely a boon for the Indian population, and I'm sure many of the Southeast Asian countries also use the same. And using that same experience, I can definitely assure even the people from West, the patients from West, that yes, biosimilars are exactly safe as the original molecules.
Great. Thank you for your insight. And I hear the same perspective from the physicians from Pakistan and even from Bangladesh. So that's great. Thank you for your valuable insight and the message. Um, let's hear a patient perspective on it. So, Tanya, has the biosimilar increased your access to care from a patient's perspective? And what would you like to know about how to gain? Uh, what would a patient would like to know about how to gain access to biosimilars in countries like India and Pakistan and Bangladesh and other South Asian countries?
So I agree with everything Dr. Joshi explained about the Indian patient scenario. Especially the first question is "Kharcha kitna hoga?" So because medical expenses are directly from our pocket, so insurance rarely takes care of medical treatments. So here biosimilars are definitely easier on the pocket, given that they're significantly cheaper than biologics and a better way to get the disease under control. For me, specifically, the reality was that it was either no treatment or biosimilars. So I hate to sound gimmicky, but biosimilars actually gave me my life back. If I had chosen to delay an advanced therapy, because I was scared or for all of the reasons you explained earlier, 3 years ago, if I had chosen to just delay my advanced therapy, I would have been in and out of hospital a lot more, developed severe complications, needed further surgeries because of my strictures, and let alone the toll it would have taken on me physically, it would have also denied me the quality of life that I have experienced with my family. So eventually, I think it is a trade off between the cost of the biosimilar versus the cost of disability. That's how I would put it.
Great. I think this is excellent. Kind of like getting the perspective of both risks, benefits, as well as the risk of untreated IBD. So I think that's great. And I think you brought up this important question. I think in a resource limited questions, "Kharcha kitna hoga?" How much will it cost? This is an important thing. And in kind of like with a similar analogy, but the pendulum when swings on the other side, then there is another saying that I hear sometimes is "Sasta roye bar bar, something like that. Okay, so I think what they have is that, what I want to give this message that cheaper is not weaker. So it doesn't mean that if the drug is cheap, it will be weak. So just remember that biosimilars are cheaper, can be cheaper, and then that's how they are accessible. But it doesn't mean that they have some weakness in it. They are similar to the biologics or to their original molecule or original biologic medicine. So that's great, wonderful. I think we had a great discussion. Um, Anyone wants to add anything, any last minute comments before we start taking some audience questions? We got some very interesting questions and we'll go through that. But anyone wants to add anything at this time, anything that is coming up? I think we covered a great deal of discussion. So, okay, so let's go to these questions here. This is the first question I have here. Hi, I'm in the UK and was recently switched while being in a flare. Will switching to a biosimilar lead to a flare? Is it safe for patients who are already in a flare to be switched to a biosimilar? So, interesting question, and I think that's a very fair question to ask. Dr. Joshi, you want to add something to this?
Yeah. So the decision to start the medication is based on the clinical or the endoscopic features in mind. So obviously the patient has severe disease, though that's why the decisions to initiate on biologic has been decided. Now, like we discussed earlier, they have been tested thoroughly about the efficacy and the effectiveness of the medication. So thereby there is not going to be any change in the way it will act even if you are in flare. So choosing biosimilar or the original molecule is not going to really affect the like treatment or the outcome of the treatment, I would say. In fact, getting onto like Tanya was saying, getting onto treatment is better than not getting on anything. So in that perspective also, getting onto drug even if it is biosimilar is going to help the patient.
Great. Yeah, no, I think this is great, and I'll just add a few things. I think it really depends about the switch. So, when I was reading this question, I was thinking like when they're saying that switching to a biosimilar during a flare, or will it lead to a flare? So I think there are two parts of this question, and I'm going to dissect it out. So one is you're doing well, and now you got a flare and you are being on a biologic, and somehow your insurance is saying we're going to get you the next dose as a biosimilar. The second scenario is you're doing well, now you got a flare, and now you're going to get a change, and that change is not the different biologic, it is a biosimilar of that biologic. So if you were on an X biologic, you got a flare, and now you are going to an X biosimilar during that flare. It really depends if that flare was because of some cause and your physician is going to give you something to help you get out of the flare, and the plan is not to change the medication or the class, and it's just now you're just getting switched to a biosimilar X because you were on this medicine X. I think you'll be fine because you got the same dose, same route, same frequency, so your immune system shouldn't be shocked by that switch. That's how I explain. The other thing is you got a flare now and you are on this X biologic, and your physician is now thinking, I'm going to put you on a Y biologic because this drug may not be working. So now you're on a Y biologic, but somehow you're not getting a Y biologic, you're getting a Y biosimilar. That will still be fine because that Y biosimilar is still the same as Y biologic in terms of efficacy, safety, potency, and their risk profile. So I think the short answer is yes, it is generally considered safe, but you have any additional question, any additional information, I think it's best to talk to your physician. And sometimes I caution all my IBD patients, even when we are doing this presentation and having this casual discussion with our great two patient advocates and physician, that not everything can be applicable to you. You can get the information, but at the end of the day, you need to sit down with your physician, your care team, and discuss and see how this information can be applied to your care, or what part of this information can be applied to your care, and how we can personalize your care. And that's very important. Because many times patients say, oh, I don't want this Humira biosimilar because my friend or my cousin or my family member had a horrible experience or they got this rash. It doesn't work that way in IBD. Everyone is individually, their immune system is so personalized that the drugs will work very differently in one person compared to any other person. Okay, so, and then one last thing, don't delay your care. Yes, we understand there may be some concerns, but if a physician or your care team is making plan and you still have concerns, don't do don't delay your care at the expense of all these things. Have a good treatment plan. So the next question is, what recommendations do you have for monitoring patients as they are being switched to a biosimilar? Also, are there any concerns about differences between inactive ingredients of different biosimilars? Dr. Joshi.
Yeah. So the basic difference between the original biological and biosimilar is the post-translational changes. So it's basically the same molecule which is responsible for the mechanism of action that you are going to use. The additional attachments to that might be different. So like you said, you have a door to open, you lost your original key and you are using a different one. So the latch and key is not changing. That sequence is not changing. It's just that you are using a key which is manufactured not by the original company but by a key maker. So that is not really going to change the way things act. So I think that is definitely not a concern. What was the second question, Tausif?
So the second part of the question was monitoring. So when you switch to a biosimilar, are there any recommendations to monitor these patients differently?
So the monitoring, so there are two parts to that. One thing is monitoring the disease activity. So that is not going to change. You are going to still do the same monitoring like patient symptoms or inflammatory markers like CRP, stool calprotectin, or intestinal ultrasound. So that is not going to change. Yes, there could be change in the way the drug levels or the antibody levels are being measured. So it is recommended in studies also that if you are using a biosimilar, you should use a similar drug or antibody titration method for that particular biosimilar. So you can't have a biological, the original molecule, and do drug levels from a kit which is there for a biosimilar, because then you are going to get discrepancy and that is unnecessarily going to increase your anxiety and make you uncomfortable that I am being switched to a drug where it is not helping me. So that's not correct. So it's very necessary that you use the same drug and the antibody monitoring mechanism for a particular drug, be it original and or biosimilar.
Yes, I think I echo what you just said in terms of not to worry about the inactive ingredients. The inactive ingredients help with the stability, the shelf life, and the delivery. For example, injection pens, or syringes. They don't affect how the drug works. And just like you gave the example, like the lock, it will still lock the door. It just the shelf life or that delivery may be different. So for most patients, these small differences have no clinical impact. But if you have a known allergy to a stabilizer or preservative, for example, latex, just that you just may want to make sure that the biosimilar may not have a latex on the device material that you deliver the drug. But otherwise, the real world data from Europe, United States, Canada, and now even from the South Asia, there where we have used a lot of biosimilars now, have shown that these formulation differences very rarely lead to any problem. And if there is any problem, that's a very mild problem. So the bottom line for the patient is that monitoring should be just like your biologics, no difference when you get switched to biosimilars. There is something called nocebo effect. Sometimes you have to watch for that. Just like a placebo effect is that you get a sugar pill and you feel like you're getting better. That's called placebo effect, right? So the nocebo effect is you're getting the actual drug and you're getting better, but you feel like you're not getting better because, oh, there was a change, and that's why I'm not better because my doctor or I got switched to a biosimilar. So that's called nocebo effect. So just be aware of that, and reassure your patient about that. So let's go to the other question I had was. I think we've covered that, but if there's anything else, Dr. Joshi, I would like to see if you have anything to add. But I think we have discussed that in our conversation about, is the efficacy lower in biosimilars compared to the original biologics? Anything else you want to add? Because I thought that we covered that their efficacy is not lower, but any additional thoughts you want to comment here?
Yeah, so even looking at from the Indian perspective, when the biosimilar was launched in Indian subcontinent, it had to go through the same mechanism. So same studies were carried out in particular centers, making sure that there is no difference as far as the safety is concerned or the adverse effect profile is concerned, and that was made very clear. So like what we have been discussing, they're exactly the same.
Great. Yes. I just have two questions left. I think then we will conclude. We will be respectful of everyone's time also. One question, and Tanya and Aisha, I may want your perspective as a patient also, because you're a great patient advocates, and that question may come to you also. And then Dr. Joshi and I will also give our take on this question. What is the best time frame of getting on a biologic or a biosimilar? Is it okay if I wait and try some herbal options first? So the question is, when should I use a biologic or biosimilar? Should I wait, try some herbal treatment, and then go for this? How should I plan that? So Tanya and Aisha. Let's
Sure.
start with Aisha.
Yeah, I was going to say, I'm sure Tanya has some more inputs on this, but from my experience in the Western, world, I would strongly advise to not delay treatment, just because of the nature of the progression of any IBD disease, the way I've seen it transpire in my experience. It's way too fast. You can't ever afford to be in this opportunity window, like, oh, I can be okay if I'm off medication. That's just never been the case in my experience. And sometimes there's, I think, like counteractive ingredients or counteractive reactions that may happen, or some masking that may happen if we're taking some supplements or herbal supplements, or even, alternative therapy. I feel, inflammation markers and some of these things the test results may be skewed because there is, if you do a colonoscopy, there may be inflammation, but it's just something that's being masked in test results or blood tests. So that's my take. And again, I'm not a medical professional, but I'll hand it to Tanya to provide her experience.
I think, thanks, Aisha. I think, so basically, I have tried alternative therapy when I was newly diagnosed with Crohn's, so about 25 years ago. And very often, when you have to wait for the efficacy of the alternative therapy, you need to compulsorily go off allopathy for it to work, which means if you've already been recommended to move on to a biologic, your Crohn's is flaring. I mean, your Crohn's or IBD is flaring. And that is not a good time for you to go off medication, do the alternative therapy, and then wait, to see if that works out. I think efficacy of any drug is as soon as you can do it, it can suppress and you can get back into remission and go back to a smoother life. That's what I would say as a patient.
Great. No, I think these are good perspectives. And so, Dr. Joshi?
Yeah, so I totally echo what Tanya said, because when many of the patients, when they come to me, when I discuss with them that, okay, you're not doing well on the conventional medications like 5-aminosalicylates, or you're failing azathioprine, I don't want to use steroids. Many patients ask this question quite often, that doctor, there have been studies, I have read it on Google, many of my seniors or बुजुर्ग लोगों ने मेरे को बोला है कि curcumin helps, जो हल्दी बोलते हैं हम लोग, that helps, aloe vera helps, there are a lot of herbal medications which are useful, can I try them before I go on to biologic? So I really sit with them for half an hour, tell them that I am using a conventional therapy which has been approved by long term data. There are clinical studies which have gone through, which tell me that these drugs are effective for IBD. Now you are failing those, that is why I'm deciding that you should go on an advanced therapy in the form of biologic. So there is obviously no question that you are stopping the medications which have been tried and tested. So that is very clear. And most of the time, what I tell them is, whatever the herbal therapies, there are no large scale or double blind clinical studies which are there to confirm their efficacy or safety. So it really becomes very difficult to kind of give you any data that they are beneficial. And most importantly, many of them have just kind of soothing effect on the digestive system, and patient feels symptomatically they are improving, but actually it is not really targeting the inflammation, which is at the peak when we are deciding to start them on any kind of advanced therapy. So obviously, when if your disease is under control and if you want to try these medications like the conventional or the herbal medications to soothe your symptoms, but to continue your therapies, that's fine. But when your doctor has prescribed you to go on advanced therapies because your condition is not well, thinking that I will just get better with with the herbal medication, is going to be a disaster. So I think you should definitely get away from such ideas.
I think you have explained it so nicely and comprehensively. This topic, I think I don't have anything to add. I'll just echo the very last part of your explaining to the patient about the symptoms and inflammation. These are two different things, and that is so important and critical in the understanding of IBD management, that your symptoms and your inflammation are two different things, and don't get them confused, because I have patients who would come to me and say, I can tell when I'm flaring because I'm having more symptoms. And so I just want everyone to understand that symptoms and inflammation not can they do not go parallel with each other. There can be time when you may have lots of symptoms and may not have any inflammation, and then there can be a time when then you may not have any symptom but you're still inflamed. So it's very hard to correlate symptoms and inflammation together. Symptom control is important because it gives you quality of life. And that's where I think that's what happens. Patients get some of these herbal treatment, some Ayurvedic treatment. It helps with their symptom, have that soothing effect, and they feel like they are getting better and their inflammation is getting better too. So the inflammation, which is the damage, may still be there. And it is the damage that causes complications. It is the damage that causes narrowing. It is the damage that causes fistulas. It is the damage that will lead you to go to the hospital. It is the damage that will lead you to have surgery. And it is the damage or inflammation that will let you to have increased risk of cancers in your intestine. So I think it's very important that when we are giving and offering a therapy, whether it's a biologic therapy, it's a biosimilar therapy, it is to control your inflammation along with your symptom control. So we are trying to control and give you a good quality of life as well as preventing any damage and complications from IBD as much as possible. The timing, as you mentioned, as Aisha and Tanya mentioned too, that I think this is a progressive disease, and sooner we can dent the inflammation, the better it is, because that's how we're going to prevent long-term complication. When we as physicians are treating our patients, we are not looking only how you're going to be doing today, tomorrow, day after tomorrow, or next month. I'm also looking at how you're going to be in next 2 years, in next 5 years, and what could be those risks that I need to minimize by giving you an effective therapy so I can prevent you from having those complications. So last question, very interesting question. Can biologics or biosimilars cause food intolerances over time? Dr. Joshi.
Yeah, so definitely no. That's a straight and simple answer, because food intolerances are usually IgE mediated, and that's where we check the IgE levels to say that there is food intolerances, whereas these are protein molecules. So the antibodies which are formed against them are totally different from what are formed in food intolerances. So that's not to compare for. You may have allergies to certain, like you were explaining, like for example, latex. You might be having allergy to latex, in which case you should be aware of what are the excipient molecules that you might be allergic to from a biologic or a biosimilar. So that's a different story. But using a biologic and having long-term food intolerances, there is no scientific evidence to back this particular statement.
Yeah. Exactly. I think the short answer, as Dr. Joshi is saying, that they do not cause food intolerance. I do see sometimes patients coming to me and say that, but no, I got this biologic or biosimilar, it really made me sick. And I just like scratching my head, like, how did that made you sick in terms of? So one thing that some biologics do have some gastrointestinal side effects, like nausea and abdominal pain. These are side effects, usually very rare. The science, what does the science tells us? The science tells us that these they are designed to reduce inflammation by targeting your immune system, and they don't interact with your digestive system. Unlike antibiotics, where when you take antibiotics, it may disturb your gut flora and affect your digestion. The biologics, they do not cause you to have lactose intolerance. They do not cause you to have gluten sensitivity. They don't cause you to have any food allergies. So I explain that to the patients. And then the patients are, but I have that problem. So sometimes I have to remind the patient that, you know what, it's that many IBD patients can have gut sensitivity. Like IBS, superimposed IBS symptoms. Even in remission, they can have a sensitive gut or IBS that can react to certain foods, not to the medication. You may have an underlying problem that is causing you to have a food intolerance, or you are not tolerating your food. You may have a stricture that may not have been diagnosed. You may have a different anatomy because you got surgery for Crohn's disease, and now you have a different anatomy, and that's why every time you eat, you may have a diarrhea. It's not that the medicine is making you go to the bathroom that frequently, and it's not that, it's just that there is a change in the anatomy. There may be something happening in your gut that may not be related to the drug. And then with time, there could be a change in the microbiome itself. And that has nothing to do with the biologic therapy we're giving. And then lastly, I explain to the patients that, some patients do have food aversion and food fear in IBD patients. And they just feel like if they eat that, even if they're feeling better, they're going to have that symptoms. And once again, it's not the biologic necessarily. So I think we are coming to the time. We have 1 minute left. Thank you, everyone. Dr. Joshi, Tanya, Aisha, from all over across the globe. We had a wonderful discussion. A lot of takeaway messages here. So what I'm going to do in the last 1 minute, I'm going to summarize this before we call it to an end. So incredible session. Let's take a moment to reflect some key takeaways. I think the main messages that I was reflecting and gathering from this discussion was that number one, biologics are not chemotherapy. They are targeted therapies. They're designed to control inflammation and promote healing. Biosimilars are safe, they are effective, and can be an affordable alternatives to your original biologic medication. They are held to the same high standards and they offer the same results in most patients. Switching to a biosimilar doesn't mean your treatment is being downgraded. It's clinically sound and globally supported step that can increase access and sustainability. Monitoring and communication is the key. If you are being switched, make sure that you ask questions, track your symptoms, and work closely with your IBD team. And lastly, your voice matters. When you are a patient or a caregiver, being informed helps you feel more confident and in control of your care journey. A very heartfelt thank to all amazing speakers today, Dr. Harshad Joshi from Mumbai, India, Aisha and Tanya, to brave and inspiring patient advocates. Thank you for your honesty, wisdom, and lived experience. You have helped make this conversation really real and relatable for everyone watching. To our audience across time zones, from United States, UK, India, Pakistan, Bangladesh, and beyond. Thank you for spending your evening or morning with us. Your presence, your questions, your curiosity are what makes these sessions like this very meaningful. And finally, a very special thanks to our generous sponsors who make this educational programs and outreach possible. Thank you for supporting SAIA mission to empower and educate South Asian patients and caregivers impacted by IBD. Until next time, stay informed, stay hopeful, and remember, you're not alone on this journey. We are all in this together. Shukriya, Khudafiz, and good night or good morning.